We're going to be talking about revolutionising care. But before we give some background and context to that, I would like to remind delegates that are in the room here today, and I will again remind people at the end of the session today, that tomorrow morning the program shows that we'll have a Global Business Leaders plenary session, which actually starts at 8 o'clock tomorrow morning. And it's 8 till 9:30. But to actually entice you to that session, please be known that there is breakfast being provided for all delegates from 7 a.m. till 8 a.m. in Room A, Block A, the same place that we've had lunch, for a fantastic lunch I might add, for the last 2 days. So I encourage you to go to breakfast and be here at 8 o'clock for what I'm sure will be a very stimulating program from 8 till 9:30 on the issue of around global business leaders. And Mike Hoden from the Global Coalition tells me that there might be a prize hidden under someone's seat, but I'm not holding my breath for that. So I'm Greg Shaw, the Director of International and Corporate Relations, the International Federation on Ageing. I will be moderating this session this afternoon. I'm delighted to welcome 4 speakers to the podium, and I'm still waiting on our 4th speaker. And I'll briefly introduce them, then I'll give a bit of a background to them. But we'll be joined by Dr. John Beard from WHO, Professor Ian Philp, Mr. Graham Pryor, and Mr. Erzon, who's the Deputy Mayor of Bakakoy. They are the 4 speakers that we'll be presenting today. And Mayor, Deputy Mayor, thank you. A radical shift in thought, innovation and action is required in the development of models and modes of care to meet the expectations of future generations of older people. Against the backdrop of globalisation, urbanisation, country and regional trends in population ageing provide unique opportunities to examine the effectiveness of aged care policy and the applicability of various models of care to younger countries. The pursuit of longevity is not without its dangers and comparisons, increasing frailty leading to falls and fractures, serious life-changing cognitive deficits leading to loss of identity and loneliness, and being alone leading to depression, and the reality is a reality for some people. Experts and leaders in the field of care innovation, evidence-based care and policy, brain health, and not brain health because Joel Satterboy won't be with us today, will talk and give some presentations on these issues today. And I'm delighted that we've had the Deputy Mayor Erzon from Bakakoy join us as the 4th speaker. Our first speaker doesn't need a lot of introductions, and that's Dr. John Beard from Switzerland World Health Organization, also a fellow Australian. He is the Director of the Department of Ageing and Life course at World Health Organization in Geneva, responsible for increasing global awareness of ageing as a driving force in shaping the 21st century public health, building a sound evidence base on ageing-related issues and developing relevant policy standards, interventions, yada, yada, yada. So,
I don't want to hear that.
Thank you.
Okay, now you're going to have to get used to Australian accents for the next hour or so. There's 3 of us. So I'm going to try and take this revolutionising care idea in multiple directions. The first direction is the idea that one of the hallmarks of ageing is diversity, and so we need to deal with a very broad range of issues from older people who may be very healthy but perhaps have high blood pressure and need that treated for prevention, to other older people who are actually quite frail and need considerable support in social care and other forms of care. Can I have the presentation? Oh, okay. This isn't me. Okay, well, you've seen somebody else's presentation. Anyway, so that's in the one dimension, and then the other dimension is when we talk about care, what are we talking about? Are we talking about formal care, informal care, health care, social care? And so trying to look at how we can form a continuum of all of those things to meet that continuum of need. And I think that's probably, if you want to remember one thing from my talk, it's that idea of designing a continuum of care to meet a continuum of need. Now I'm going to start here, and this is a very rich setting. This is in The Hague in the Netherlands. It's a high-level meeting of very important people. We've got the Deputy Director of the OECD, the Assistant Director General of the World Health Organization, the Secretary of State for the Netherlands, a very high diplomat from the EU. And these people are sitting in a meeting we held looking at the issue of long-term care and how we might revolutionize it. And you will see in the background there's a drawing, and throughout this meeting there were people there completing this drawing, so it became a record of what happened in the meeting. And I'm going to take you to that. But I'm going to end by taking you to a very poor village in a very poor country and introducing you to an old man, and I want you to learn from that old man what he could teach these people. So we go from here. This is the record of the whole meeting, and we're going to look at the output from the meeting in terms of what it recommended. And you'll see here, and it's probably too small, and it's in English for those of you who don't speak English, but essentially on this side we've got where we are, and on the other side we've got where we want to be. And where we want to be was determined by this large group of experts as an adaptable, universal system that helps older people to maintain the best possible function, well-being and social participation, to manage disability and to die with dignity. And some key messages about the characteristics of such a system are written up here, and again you won't be able to read them, but I will read some of them for you. It needs to be evidence-based. It needs to empower older people. It needs to have equity of access. And these are things which we all talk about all the time. But I think this idea of designing a system for the continuum of need, which is in the broad population, and it also provides an integration between the health care they need, the social care they need, the formal, the informal care, and all of the above. But then what happened was all of these points are actually concrete steps that can be taken towards achieving that goal. And so some of them, for example, related to the fact that we use a lot of terms that are very similar but mean very different things to different people. So, for example, there's a whole profession around palliative care. There's a profession around long-term care. They both are saying exactly the same things, well, not quite, almost exactly the same things, but they think they're quite distinct. There's a whole industry around chronic care. We don't even know how terms like frailty, what do they mean? And so one of the concrete steps we thought was really important was actually trying to bring some clarity to all of that. Some of the other steps were around standards, because what happens at the moment, particularly in low-income countries, and particularly in private sector nursing homes, well, anything could be happening. We don't know. There's no guidelines for what should be happening, and there's no way of holding people accountable for whether they're actually doing them. And so we thought that actually trying to develop some standards, what is appropriate, even in poor settings, and what's appropriate in richer settings as well, would be another very useful step. We also thought that the idea of continually assessing people, because at the moment, what happens when you talk about long-term care is suddenly somebody becomes eligible for long-term care and that's it. Then they just receive care. But in fact, there's no step there. It's just part of a continuum, and they've reached a point where they can no longer look after themselves independently, But that, first of all, may be reversible. It may be that rehabilitation is effective for them. But it also may be that they only need a little bit of support for a certain period of time. And if we do the right support, it might actually prevent them deteriorating further. But we're not thinking about these things because we think of it as they're okay or they need care. We're actually not thinking about that continuum. And so trying to come up with some models about how we might think about that was also something that was important. But there were also some really challenging questions that came up through the meeting. And I thought I'd pose them to you. I'm not going to give you the answers, but the first one is, who's responsible for this? And we heard this morning in an earlier discussion about the role of the family. And certainly the family has traditionally taken on a lot of care of older people. Although family is often code for women, and in the 21st century, women may have other aspirations. And so yes, they may want to choose that role, but it shouldn't be forced on them to the point that as a 20-year-old, their family thinks it's not worth giving them education because really their role is to care for people subsequently. So, and as we get more and more older people, we're going to find that burden on younger people, particularly women, increases. And so in China at the moment, it's totally unreasonable for a family of perhaps one couple to be responsible for 4 parents and 8 grandparents. It's just not sustainable. And so the government in China has said, no, okay, we also have a role in this. And so I think this balance between family and government is probably the answer, but it will be interesting to see how the discussion goes. The next question is, okay, if we're saying governments do have a role in all of this, how do we convince them of that? Because on the one hand, I think I can argue quite coherently that if they invest in health and if they invest in education in middle age and older age, they will get healthy, well-educated, trained older people who can contribute, and there's an economic benefit. I think that's a very easy argument. But the argument for saying, okay, how do you provide financial security and how do you provide long-term care, it's more that that's a real burden and a cost, and they will try and minimise that expenditure. So how can we frame that for them? So we've been doing a little bit of work with the World Economic Forum, and this is some of the early thoughts, which is perhaps we shouldn't be thinking of these things as costs. So you'll see on the left here, we have what I said to start with, healthcare and education. You might actually think of them as an investment because they're an investment in good health and an educated population, and you'll get a return for the ultimate goal here, which for economists is socioeconomic development. But down here, these are the things I think we're talking about today, or some of them in terms of care. And yes, they benefit the older person, and you could think that that's actually a repayment of the investment that older person has made across life. But they actually also benefit social cohesion. And this is actually really crucial, that everybody in society, I think, would like to think that as they get to a point where they really need support and care, that it will be available to them. And if that's the case, then there's more cohesion through society than if it's the old versus the young, as we often hear in many of these debates. The next question is, if we're looking at all of this, how do we move from talking about individual types of care to creating a system? How do we create a system where health services talk to social care services? How do we create a system that they integrate with informal carers? And that's really challenging. The next one, and this is something that repeatedly comes up as absolutely crucial, how do we support caregivers? And there are many ways we can do this, but I thought I'd just tell you about one initiative we're doing at the World Health Organization, which is looking at dementia. Now, there's very clear evidence that being a caregiver for someone with dementia takes its toll on you as an individual, in your health, your well-being. And there's also clear evidence that unless caregivers are fully informed, the care they deliver is inadequate. So what this project is about is developing new eye technology that can be used on an iPad or things like that, which can be given either to a local healthcare worker, this is in very poor countries we're talking about, or can be shared with family or other community caregivers so that they can have access to all the information that is needed to actually understand what's going on and provide appropriate care. And in doing that, it's been demonstrated that it actually improves the health of the caregiver, the health and the well-being. There's very clear evidence that even though you've got the same burden in terms of the same individual you're caring for, if you know what it's all about, that burden is much lighter. The final question I've got is, how do we draw on the resources of older people? Because when I framed the question earlier about whose responsibility is it, we talked about the family, we talked about government. But I think there's this other wonderful resource which we have available. And this is where I'm going to take you to a very poor village in the Irrawaddy Delta of Myanmar. And this village is so poor, they didn't have electricity, they don't have running water. It's about as poor as you can get. And but what this village is not poor in is human resource. There's actually a significant number of older people because Myanmar is quite a rapidly aging country. And in a project with HelpAge International, that community of older people was brought together into what they called an older people's self-help group. And they were given the capacity to understand some of these things, to understand how they can work as a group to actually support not just the older members of the community, but also the rest of the community as a whole. And here's Mian Taint, who is an 85-year-old living in that community. And what he did with his friends and partners in this older people's self-help group, they had a very small investment in the first instance which allowed them to buy some seed rice. And with that seed rice they could finance ongoing crops. And with the return from the ongoing crops they then managed to get more seed rice which they could then give out to sell out at a reasonable price to younger people and continually get a return. With that money they managed to bring electricity to that poor village. So this was not an initiative that was just a benefit to older people. But it did also benefit older people. I asked him, what happens if somebody is sick? What happens if somebody has a stroke? And he said, it's really funny that you mention a stroke. Because somebody, I can't remember her name, over there in the village had a stroke 6 months ago. We didn't know what it was. But we had this guide from HelpAge which said, okay, if these things happen, these are the people you need to talk to. So we knew who we had to contact. They came along, and it was the healthcare worker, and they diagnosed a stroke. And they said, there's nothing we can do to cure it, it's happened, but there are things you can do to improve this person's outlook. And here they are. Here's a guide for physiotherapy. And that older person, in the poorest of poor settings in the world, was able to receive the care and support she needed for rehabilitation and physiotherapy from a group of older people just because they'd been enabled. And I think that's an incredibly inspiring story which we did take back to that high-level meeting. And it was interesting that that meeting was in the Netherlands where they have a long-term care insurance scheme and which they say is financially unsustainable. It's got the biggest benefits that anywhere in the world for people who require long-term care. And their complaint is that what's happened is the more we give, the more families say that's nothing to do with us. It's the government pays for that. And they said, actually, you know, maybe this is something we can think about in the Netherlands. And I think they're right. That's my attempt to revolutionise care.
Thank you, John. I'm sure all of us who've had any relationship with the long-term care system would certainly like to see a uniform or a standard vision of a system of long-term care which not only fits developing countries but developed countries more uniformly. Certainly standards do vary, and John highlighted those from rich countries to poor countries. Models of care beyond the mere admission and talking about how people and funding is linked to people once they get into nursing care, the incentives to look at how people might improve functioning perhaps not there. Creating a new system across the care continuum, including carers, certainly work that they've identified. And I was certainly impressed in defining, where he was talking about defining whose responsibilities it is around care, with the example from Miramar where a village has come together to support better health outcomes for a stroke victim. So thank you, John, for that presentation. Our next guest will be Ian Philp from the United Kingdom, and I think they've put up the Hall and Pryor program again, so they're a little bit wrong. But Professor Ian Philp is the Chief Medical Officer from Hull and East Yorkshire Hospitals and is the Honorary Professor for Healthcare of Older People at the University of Warwick. I'm not going to read his long bio, but I will give another brief statement. He established the Sheffield Institute for Studies on Ageing, which won for the University of Sheffield the Queen's Award for Higher Education in 2000 for research into improving the quality of life for older people. So I'm sure he can add and contribute a lot to this discussion. Please welcome Professor Ian Philp.
Thank you, Greg. Thanks to everyone for staying. I'm sure people are feeling quite tired and had their minds expanded in many ways. My job is to try to expand your minds a little further in this talk. I've only got one slide, and I'll explain the last point on the slide at the end of my talk. But thank you particularly to IFA, to Turyak, and to our many wonderfully hospitable Turkish colleagues who have made me, and I think I speak for all of us, so welcome here in Istanbul. In the last couple of days, I've had some powerful conversations with a number of people, and I was going to mention them, but there are too many. It would sound like the Oscars. But people have reshaped my thinking about how we should be addressing the challenge of care in the 21st century for older people. And I'm grateful, though, and I will just thank two people, Jane Barrett and Greg, for helping to engineer some of these conversations. I've rewritten my talk to try and connect the Easy Care project to the thinking that I now have, and to throw it back to you for discussion and debate. But I will need to explain the Easy Care project in brief. And this is a bit of it has a personal history to it. The person who inspired me to become a doctor working with older people was a professor called Jimmy Williamson, Edinburgh professor of geriatrics, one of the pioneers of my specialty. And he wrote one of the classic papers on healthcare for older people, published in The Lancet in 1964, and it was called Old People at Home, Their Unreported Needs. And it described how 2/3 of the most significant threats to older people's health were not known to their primary care physician. And I would contend that 50 years on, the same is true today in most parts of the world. And as a response to that challenge, in 1989, on a fellowship I undertook with Robert Kane in the United States, we developed an adaptation of the science of geriatric assessment technology to attempt to use it in a primary care setting to help identify those concerns and priorities that older people had about their health and make them known to the system and enable the system to respond in an appropriate way. And that work was initially followed on in Europe, mainly, with a number of projects in a number of European countries to take forward the concept into a practical approach with an assessment tool, with training materials, with guidance. But another key benchmark in the history of this project was the IAGG conference in 2009, John, you'd recently taken up your post as Director of Aging and the Life Course program at WHO, and you challenged me just before the conference to globalize this approach and see whether it would work in poor, middle income and rich countries, in different cultures, Islamic, Buddhist, Judeo-Christian, in countries which were technology rich and in countries which were technology poor. And my colleagues and I in our network took up that challenge, and we now have experience of use of the system in 41 countries that fit all of the above classification. And we know now that we have a stable assessment instrument and a certainty of approach to how we should use it in all these settings. The assessment instrument, which is called Easy Care Standard, covers 7 domains. Seeing, hearing, and communicating is one. Getting around is another. Looking after yourself is a third. Your housing and your finances is a fourth. And I was asked to make the point about the vital need to integrate housing with health and care. Safety and relationships, including relationships within your family and with your caregivers, is another. Your mental health and well-being, we've found, has been one of the most important domains. And finally, we have a domain around staying healthy. We've found that this approach and assessment tool has become highly valued and is acceptable to older people and to frontline assessors, often care assistants or volunteers, sometimes health and care professionals. We've found that it is reliable, and we've found that it can produce 2 or 3 summary scores, one of which I'm most confident in is called the independent score, which seems to correlate with an individual's need for support. We found that when we look at the data that comes back at a population level, interesting patterns where the older people at the end of the assessment is asked, is there 1, 2, or 3 things related to your concerns that you'd like help with right now? And normally they only say one thing. In Tanzania, it was about access to toilet facilities. In Warwickshire, it was about the fact that they were in severe chronic pain. Elsewhere, in many settings, it has been about their loneliness. So we get data which tells us something about the needs of our older populations that we are serving. So this isn't just an instrument, it's an approach. I think a revolutionary and disruptive approach to basing the response to the need of an individual and the development of the health and care system to what older people themselves say they are worried about and what they want help with. Now, the system always needs to be localized. We need, in every locality when it's used, to choose which older people we want to target. We need to think how we will identify them. We need to think how and who will undertake the assessment with them. We need to draw up an understanding of how we can respond to identified priorities for support. And we need to decide how we want to manage and use the information that we gather from the assessment. But we know we can do this. And many people say, what's the point in finding out what older people want if you can't do anything to help them? I hear that in very rich countries. I hear that from development workers in poor countries. But I can tell you that our experience is nearly always something can be done. And always, older people are appreciative that we have listened and we are trying to help. We also know from our randomized controlled trials that we've done in some countries that use of the system in a structured way reduces the number of times an older person needs to go into hospital for expensive care, delays the time that older people may need to go into permanent forms of institutional care, raises the level of independence and capability of the older person, and improves their well-being. We also know that combined with training, our system can help identify problems such as dementia and the onset of frailty at an earlier stage than the system would normally identify people with these high levels of need. So we know a lot about this approach, but we want to move from understanding how this approach works to implementing this approach in a scalable and a sustainable way around the world. We know we need to do more studies on the impact of the system, and I'll be delighted now to work with the World Bank to look at the micro and the macro economics of the impact of this approach. And I'm delighted that I'll be working with some of the most wonderful researchers in the world, like Professor Dupeng in Beijing and others, on using this assessment within well-conducted longitudinal studies to see what it tells us about predicting and responding to the needs of older people. And I'm very excited at the opportunity to conduct one of these gold standard studies in Turkey, I hope, from conversations I've had with a number of colleagues here. So, how does this approach fit and support a revolution in care? I will mention 3 people now whom I've had powerful conversations with and listened carefully to what they were saying. David Ryan from Intel described how we need a new social contract for the 60-plus population to move away from welfare and care and to move to empowerment and capability. Linda Fried described how a child born today in a good environment with good health and care can expect to have 30 years of meaningful life above the age of 60. And Amit Sibanchi described how if we could use the huge human capital of older people remaining productive in the years beyond 60, we could add 15 percentage points to the country's gross domestic product. These facts change, indeed I would say revolutionize, our future and the future of aging. And in a modest way, but in a global way, Easy Care can make a contribution to that agenda. First, Easy Care by its nature shifts the focus on the older person's care from the provision of care to enhancing capability and independence. Second, Easy Care moves away from a response that classifies and gatekeeps and directs care to older people to one which empowers older people to find the solutions which work for them. Third, the Easy Care approach changes our approach from a professional or a system definition of need to a user-defined definition of need. Fourth, Easy Care moves us, potentially, or helps to contribute to move away from a segmented world of poor, middle income, and rich, of Buddhist, Judeo-Christian, Muslim worlds, of technology-rich, technology-poor, to a connected world where we face the same universal challenge and we can respond with a common global approach. Fifth, the Easy Care approach allows us to rethink aging from an economic burden to an economic asset. And sixth, Easy Care helps us rethink family caregiving from a burden to the contribution that older people can make at the apex of their families. Now, I've had the opportunity here to make lots of plans with a number of fantastic people for our next 5 years' work. And I truly believe that this meeting is as important as the 3 milestones I described in the history of this 25-year project. And I thank you sincerely to all of those of you who have helped with the program, from colleagues in the Easy Care Network who are here, who've been doing research in their countries, to many of our advisors, and to some of my new friends. And I look forward to working with you in the next few years on a journey where I think we can revolutionize the care of older people throughout the world so that we can give the children of tomorrow and the older people of today more years of a meaningful life. Thank you very much for your attention.
Thank you, Professor Phil. When I was listening to that presentation, I was thinking, it's been in the development for 25 years. In what fields could something be new that is 25 years old? And from that presentation, it certainly showed that in the area of older people and assessment and care, something that was thought of 25 years ago is certainly new today, where we're actually putting a whole person at the centre of the frame in terms of looking at what their needs are, shifting them from a burden to an asset. That was certainly the message that I got through this new Easy Care assessment process. So thank you for that presentation. Our next speaker is Mr. Graham Pryor, the CEO of the Australian-based organisation Hall & Pryor that specialises in residential care. It's become one of the largest aged care providers in Western Australia, with 13 homes within the state, as well as 6 nursing homes outside of Western Australia in New South Wales. The Hall & Pryor commitment and dedication to providing high quality aged care, offering choices and accommodation and health services that are important to residents with the highest standards of professional care and dignity. Graham is certainly well known in the Australian context. He has also been appointed a government appointment to the Federal Task Force looking at the restructuring of aged care funding and Commonwealth outlays. So he is certainly one that can provide us some context of the revolutionising care from Australian standard. Thank you.
Thank you and good afternoon. I'll talk for about 15 minutes. This presentation normally lasts about 25, so I'll cut it short. What I do want to say is that the journey has only just begun. I've been involved in care for 20 years, and it's wonderful to hear a topic of such importance being promoted today and with great speakers. But I personally believe this journey has really yet to begin. We're talking about it, we're starting to do some good research, people are gaining some confidence, but technologies really haven't arrived into our space. The technologies are out there, the science is out there, but they haven't really moved in yet into Aged Care Mission Central. I just want to thank some people here for inviting me to speak, particularly Dr. Ganga Haradan, President of IFA, and of course Dr. Jane Barrett, the Secretary General. As I said, I've been involved in aged care for 21 years now, and I absolutely love this territory. You name it, I've done it in aged care. I've tried just about every innovative idea you can get your hands on, from pressure ulcer research to medication to systems to technologies, to promoting women into executive positions in care and helping them gain a lot of confidence. We employ 80 managers in the program and 6 executives. I'm happy to say of the 80 managers, about 80 are female. So it's very much an RN model of care. We employ 1,300 staff, and most of our residents are very, very ill people requiring permanent 4 to 4.5 hours a day of permanent intensive care. To give some background here, if you fly from here to Dubai, that's the length of the distance from Perth to Sydney, and we operate 400 beds in Sydney. And if you fly from here to Bucharest, we operate 200 beds or thereabouts down in a place called Albany. So Australia is a very vast country, and distance is no impediment to running a good care program. We have distilled our whole philosophy as an organisation down to compassionate people dedicated to care. So people to be recognised as employer of choice, services to be recognised as a destination of choice for health and aged care, not just aged care, but health outcomes, and also health outcomes for spouses and partners, and for some family care, and a brand. Australian aged care has been going for a long time, and there are some good brands recognised doing good work in revolutionising care. What is health? I think Abraham Lincoln does summarise this very well. It's been talked about the last 3 or 4 days. Professor Yitzhak from Israel raised this yesterday. You can live to be 120 years of age, but what's the quality of life through your journey for every year? I like this particular reference by WHO in 2000 that said many of the major determinants of better health lie outside the health sector. They certainly include clean environments, effective administration, fair societies, access to information and knowledge, and access to energy, water, sanitation services and shelter. So we do carry the destiny of our own healthcare needs, but from even working in a place like Australia, these factors here have an enormous impact on the quality or the poor quality of care inside residents we actually have to care for when they arrive on our doorstep. The futures of aged care. The baby boomers are certainly ageing and making their presence felt. Technology is making real ground-breaking benefits. It is slow, but it's coming our way, all forms of technology. And of course, medications and the campaigns medication are adding to our lifestyle. The models of care, we work with all these various models of care. The one I do like the best that has a level of prediction beyond its intelligence, and I've had to work with our people to prove this with the Commonwealth Government, is the RN model of care, the female leadership. I am quite committed to. It works very well. And of course, team-based environments. An emerging trend in Australia is a nurse practitioner program working alongside GPs, not replacing GPs, but being a real partner in care. Technology-enabled consumers, they're on the rise, and they are looking for a far better relationship for their care in 5, 10 years' time, or 1 or 2 days' time, or the care for their family. In Australia, we've had a journey with our government. The government runs the aged care program in Australia, the federal government. It has run it since 1949, so I'll cover a few moments. And some trends I've observed in the last 30 or 40 years is conservative governments tend to emphasise voluntary behaviours, choice and individual responsibilities for our own welfare. We currently have a Conservative government. The government that just left office 2 months ago, or 2 weeks ago, was a Labor government, and they really emphasise a collective approach, very community orientated, universality of access, and universality of definition of aged and healthcare is very paramount, and a compulsory health cover. So pick a government as to where your journey on revolutionising care can begin. The journey in Australia I'll cover in the next couple of minutes. In 1900 we formed the Australian Federation with grand visions. The Department of Health was established in the 20s. The Department of Health was dedicated, like all government, to depression and recovery in the 30s. And then we had major themes every decade, from vaccines to viruses. In the 60s, change in attitudes, mainly driven by women, access to all sorts of healthcare outcomes. Community care took a major focus in the 70s, and health for all. And the Department of Health and Ageing issued a document about 3 or 4 years ago, and it came to a conclusion that in the 21st century, it really wants to focus on technology and the gene century. My view is that from this moment onwards, with people like Dr. Wood and Professor Ian Phillips, that we can certainly bring to our world the dawn of a fantastic era where health and aged care workers are no longer just workers, blue-collar workers. We can take them on a journey and make them knowledge workers and give them knowledge to care for our people in care. Not just nurses, but carers, people in administration, and also, most importantly, doctors and nurses. So what's the journey in Australia? The journey of revolutionising care, as I said before, has only really just begun, but let's cover some history here. In 1949, the government of the day was under a lot of pressure to take control of the ageing issue in Australia. So in 1953, we had a National Health Act established where Commonwealth outlays would fund care requirements across all of Australia. And you can see here the government has been very active every decade ever since that moment, and up until recently we had in 2012 on the federal government, before it fell in June 26, passed legislation that was very, very revolutionary, very forward-thinking, and it's been called Living Longer, Living Better Reform Bill, and it's going to really revolutionise care in Australia. This package really is looking at today and over the next 10 years to reshape the way aged care will work, to be a more fairer and much more nationally consistent aged care system. A much stronger focus on clinical outcomes and ADL outcomes, and a strong package around providing much more care in the community and care for people who want to age in place. As I mentioned before, this package got passed through our Senate 30 minutes before the government fell, and so it's really a major outcome for the previous Labor government. Why the reforms? Providers wanted reform. They wanted to be sustainable and to have an incentive to provide large infrastructure, both technology and physical. Consumers wanted reform. They wanted choice, fairness and protection. And I must say, I have some consumer colleagues in the room here, and they did do an outstanding job in driving this Commonwealth reform as consumers on behalf of the population of Australia. And the government wanted reform to focus on the changes coming in demography. They wanted the industry to be more sustainable, and the workforce has to be built for the future. Workforce is currently about 300,000 people, and over the next 30 years has to grow to at least 800 to 1 million people permanently employed in the Australian aged care sector. So the key focus of the reform, as I mentioned before, is user pays, consumer choice, products and services on offer, so you go shopping for your care requirements, how to pay for those products and services, and of course a very transparent government portal, My Aged Care website. As mentioned earlier, an enormous focus on increased care standards. They've taken care requirements from this level to through the roof from 1 January next year. What will it mean? Higher accountability for performance, nationally benchmarked data, where people like Ian and John could work with us on things like easy care, and we can relate to that. A much more competitive sector, and an investment over the next 20 years of at least 40 to 50 billion, as I said, $1 billion into infrastructure. Demand pull services, deregulation of supply, and a very, bottom point, very high care specialisation, high care. So let's think about revolutionising care the last 2 or 3 minutes I have here. As I said, I still think this journey is only just beginning. For those people who think it's in Australia it's been going a long time, I think that's not the case. A quantum shift is now required, a fundamental paradigm shift from what took place up until early June to what will take place from January next year. Very strong focus on clients, consumer-driven outcomes, not just care. Market-based factors of competition, efficiency, outcome-focused accountability, and a much bigger role and behaviour of the federal government on policy, on regulation and on funding. Is this unique to aged care? Is aged care, and some of my managers say to me and executives, well, aged care is safe because there's an endless queue at our front door. And I say that's absolute rubbish. That's absolute nonsense. If you think you can provide the same old service, the same old way to the clients of the future, you will not have your job. I'll give you some examples of this. MySpace was the #1 website in July 2005, and it's virtually out of business in June 2013. Kodak is a great example of a great business born out of a fabulous time in America. It actually designed and patented digital camera in 1994, but it failed to align its business model with changing preferences, and Kodak filed for bankruptcy last year. And of course, Nokia, one of the saddest stories of the last century, last 100 years, is Nokia was sold to Microsoft for $5 billion or 5 billion euros just recently. Had a market capitalisation of 260 billion, and here it is today. So this message applies to providers, also applies to communities, and applies to governments. If governments don't want to provide quality care over the next 10, 20, 30 years, then those governments are more than likely destined to be put into the dust heap and replaced by new governments that will provide care for our elderly citizens. I'm stuck here. Okay. Science and technology. Science is coming. I think it's going to be science over intuition. This is not a challenge for doctors at all, far from it. But we want our GPs, we want our researchers, we want our medical education programs to really bring science and technology into the teaching programs of doctors and nurses and challenge them to do away with a bread and butter approach just to judgment and intuition. It's a bit provocative, but if you talk about a journey of revolutionising care, I think this has to be put in place. This doesn't mean we have to do away with intuition of the GP or the specialist, far from it, but I'm saying to these organisations, you have to go with the modern times and you must embrace science and technology, and you must help our people get better decisions through a technology platform and not just your judgment and experience. Clinical pathways, knowledge pathways, and the last point I'm saying here is, in the Australian context, the federal government is now going to have the most powerful tool it needs for planning, and it's called the arrival of big data. They will collect data beyond anyone's imagination on care requirements for all population centres and care outcomes. They'll be able to measure it and determine whether GPs, whether care providers, whether communities are providing optimal care for those people in that population base. This is what I will cover for no more than 10 seconds. This is the platform that, this is version 1, which has currently been put in place inside the organisation I currently work for. Where are we today? We have very much a paper-based experience-based. We're very compliance-focused. We are either efficient or inefficient, all depends on how you approach it from the governance of the organisation. We're largely isolated, but we do deliver care. Where do we want to be in the next 5 or 10 years? We want to be totally and utterly enabled by technology, one system, interoperable, and capable of transferring data between the whole care continuum platform to government, to GPs, to pharmacies, to hospitals, etc. It has to be evidence-based, and not just evidence-based, but hungry for evidence on all outcomes at all times. Why medication levels beyond 10 in a medium for a nursing home? What's behind that? Challenge that. Highly efficient, highly effective, appropriate care environments, and really chasing the continuum of care. If someone comes into your care, they want to go home, we'll take them home and care for them at home. It's their choice. As I mentioned earlier, management of my 80 managers I work with, all of them use technologies, and all of them are Apple converts, and all of them are financial controllers, medication managers, clinical outcomes. They are walking, talking women of the 21st century. And we want to optimise the workforce outcomes. That's our vision, and I think we have commenced the first 2 or 3 years of that journey, or 5 years actually. I won't cover this now because I'm out of time. I just want to conclude some creative innovation and action. We have put in place Web 2 across the organisation. We have spent an enormous amount of money embedding electronic care systems and technologies, and it is delivering better care and saving money and providing high levels of certainty for doctors and nurses. Partnering with research programs, I think, is mission critical for any provider of the 21st century. Building better environments and collaborating for dementia-enabling environments. This is some great work happens in the US over this. Some great work happens in the UK and Scandinavia. And Australia is slowly starting to catch on and trying to catch up to these people on designing and operating better dementia-enabled environments. Governance, governance, governance. I can't stress how important this is to be creative and to share with the whole world your governance. If you have a facility that has a mortality issue or has a turnover of staff issue or has a toxicity level above the norm, then share it with the open world. Have the courage to be creative and share that with your community. I think it's very, very important. And reinvest all of your surpluses into a survival program for the 21st century. So in summary and conclusions, not only do we have to differentiate ourselves as a provider, but governments and sub-governments also have to focus on making sure that their care platform for the next 5 years is better than the care platform they funded and controlled for the last 5 years. And their survival will depend on the quality of that care platform, and my survival the same. Knowledge creation, it is wonderful to hear about easy care. I think it's a fantastic opportunity for not only the universities in England, but also other places, but really it can help us with that. So I'm being told to move. I'm just going to give you my top 10 points on how to be creative and survive this revolution coming. 1, embrace technology and big science. 2, build knowledge pathways. 3, teach the client base to jointly manage care, joint production, and take them on a journey with you. 4, build infrastructure that is future-focused and safe economically. And 5, have a community orientation, total transparency. Only build for sustainable economic success, otherwise the government will need to bail you out in the future, which they won't want to do. And permanently build human capital. Develop, educate, secure and inspire these people, and work collaboratively with governments at all levels, at all times. Plough back the surplus and create possibilities. Thank you very much.
I always do enjoy listening to Graham, particularly given that some 11 years ago I was involved in the Australian aged care system, and it's something I look back to fondly, but particularly looking at where they've moved to in that time. I was particularly taken by Graham's opening remarks about the journey is yet to begin, and I think it is a journey, but it's one that really focuses on the consumer and client, and it's got to be consumer driven, and I think our speakers to date have really shown that. The other thing that I took away from Graham's session, which was interesting, was I'm very glad that I got rid of my BlackBerry phone. Who actually owns a BlackBerry phone? There's a few people still in the audience. Now, I think their shares dropped down to about $3 last week from about $120. So I don't think they'll be on the market for much longer, similar to that of Kodak and Nokia. So thank you, Graham, for those remarks and comments. Our final speaker today, and it's with interest that I actually talk about this because I did hear of a report in a newspaper where the city or the municipality of Bakakoi actually got mentioned for the work that they're doing around technology. So I'm pleased to present Mr. Yevent, I'll get the right, Ezazong, to present their presentation from the municipality of Bakakoi, and he is the Deputy Mayor responsible for the Health Department. So please welcome him to the podium. People, this presentation will be in Turkish, so if you don't have earphones on at the moment, you might want to put them on.
Değerli konuklar,
Distinguished guests, I would like to wish you a great day and great days ahead. Needless to say, healthy life, quality of life, right to life, they are the most valuable assets for us. Distinguished guests from our country and other countries, you have this mission to secure this quality life, and you are also ones catering to this need. So thank you very much for taking this as a mission, and thank you very much for all your efforts. Especially in the rest of the world, we can see the fertility rates are declining, and is also increasing the aged population. As countries develop, we see children, people with disabilities, and elderly people. The service provided to those groups is also important to understand the development level of the countries. That's why, as countries, as governments, and as citizens, we all have much bigger responsibility. And as governments and local governments and authorities, you will see the service that we are offering to people. And I would like to tell you the services that we provide to Bakırköy district. So our district has really a very big number of elderly people. In Turkey, the total rate of people about the age of 65 in Turkey is 5.51, whereas in our Bakırköy district, it's more than 12%. So it is twice as much and higher than the Turkey's average. That's why we are offering some special services for the elderly people. What kind of services I'm talking about? First of all, we offer some vouchers to the elderly people. These are shopping vouchers, so every month we transfer cash to the elderly people through the bank that we signed protocol with, and they can use this cash to make shopping, to to just cover their shopping needs. And we also provide food to the elderly, because we do believe that it is the duty and mission of the governments and local governments to provide service to these people and to make sure that they're in healthy condition. And that's why we offer also healthcare services at various hospitals and clinics, and we also try to provide healthcare services at home. What's more, we also try to support our elderly people who suffer from loneliness by placing them into some nursery homes. We make use of all the opportunities of technology. And in case of the need and in case of emergency, we have some emergency support lines which will also help us monitor elderly people with specific disease, including Alzheimer. So I would like to wish you great days and success in your work. Thank you very much and welcome once again.
Is there any sound to the video? No?
Yani geçim hususunda yani birçok avantajları var. Sonra hiçbir baskı yok, hiçbir ikaz yok. Her şeyden evvel yani bizlere gayet saygılı ve seviyeli davranıyorlar. Bu benim şahsım adına konuşuyorum. Benim için çok değerli bir nokta. Yani saygılı ve seviyeli olmalı bir nokta. Hanımsız, Mali Hanımsız, Ayşe Hanımsız, Fatma Hanımsız, Ahmet Bey'siz bey kelimesi, hanım kelimesini eksik etmiyorlar muhatap olurken. Bu insana bir güvenç veriyor. Yani bir ön planda olduğunu hissettiriyor.
Huzur evimiz ilçemiz merkezinde yer almaktadır. Minimum 10 yıldır Bakırköy'lü olan sakinlerimiz gece 11'e kadar dışarı çıkabilirken yılda 3 ayda izin kullanma hakkına sahiptir. Böylece mekan değişimi ve alışkanlıklarından vazgeçme sorunu yaşanmamaktadır.
Thank you for that presentation, and I always do enjoy watching videos of older people, particularly who are complementing the services that they receive. I was particularly interested in the municipality of Bakırköy in that it has double the ageing population of most other areas of Turkey and the services that they are providing. So I commend you for the cash transfers, the food, the healthcare services, and the greater use of technology. I'd like to open the floor for any of the delegates that remain who haven't snuck off for any questions to any of our panellists. So raise your hands for questions, or are we, yes, Ms. Marks. Do we have a roving microphone down the front? Thank you. Down the front this way. Hold your hand up for those that want to speak. No, down this way. No, he's come down the back. So right down the front here. Yeah. Keep your hand up, Ruth. Keep your hand up. Thank you.
No problem. Thank you.
Thank you. The floor is yours. And please address your question to which panellist?
Thanks very much, Greg. Ruth Marks, IFA Director and employed by the Seren Housing Group in South Wales in the UK. We talk about informal and formal care, and informal usually meaning family care and not paid, and formal care usually meaning professionally provided and paid. But due to various contractual and policy agendas, the pay is often very low indeed. And I'd be interested in the panel's views on the value that we place on formal carers, and by default, the value that we therefore place on older people. And do the panel think that this would change if we really had truly joined up health and social care provision? Thank you.
any of the panellists? Or John, would you like to tackle that, or press the button?
Yes, Ruth, it's obviously a crucial issue. Ruth, by the way, was, I think, the world's first commissioner on ageing. So, I suspect that a lot of it will depend on the economic argument. And the economic argument, I think, is pretty clear. That is, if you have trained, good quality social and long-term care workers, it actually means that, well, not only do people receive better care, but it keeps them out of hospital. It reduces the likelihood that they may be institutionalised if the care is in non-institutional settings. But I don't think we make the argument clearly enough, and I think we need more evidence. And then we have to fight what we talked about earlier, is the stigma of ageism.
It's a really, really, really important issue, Ruth. We have invested, as I mentioned to Ian a few seconds ago, over the last 2 decades, a lot of money and value in this area. And it's not just money, but money is, take-home pay is very, very important for these people. Otherwise, why would they do it? And it's very tied to the economics of the whole situation. The economic prosperity of the country and its own financial balance sheet plays a huge part in this. In the Australian context, the Australian government has yet to be pushed into a situation where it agrees to legislated 4-year funding terms. We've almost got them there, but haven't agreed to it for one very good reason: it's economics. Having said that, though, after all the huffing and puffing, the government has agreed to make sure they fund decent pay increases for our staff. So in 2005, for argument's sake, in Western Australia, we have 1,000 staff on an EBA, Enterprise Bargain Agreement, and at that time, the take-home hourly rate for those staff, carers, as you understand, Ruth, very well, was no more than $14 an hour, pretty woeful, plus entitlements. Now they're on 21, going to 25. But that's economics at play, and it's a very delicate issue. So it's not just money, though. We've identified about 21 key critical factors to the relationship between your formal care staff and her or his work environment. Pay is number one, but there are 20 other factors that are very important to them. Career paths, security of their position, value, respect and trust are vital for these people. Working for a very good boss and a good organisation that's ethical and honest, these all come into play. Not just for care staff, but also for the RNs and doctors as well. So all this together, we have to value these people, and not just value by take-home pay, but by the relationship we all have with them, whether it's people like Professor Ian here who helps with research and become better carers, or myself doing my job to make sure we stay alive and keep them employed.
Thank you, Graham.
Greg, can I come back too?
Yes.
Just a quick one, because I was thinking, I think that this is also why it's important that we start doing rigorous evidence, knowledge generation, research, and that we make ageing not the cottage industry that it has been, but we bring it into the mainstream and start dealing with it with respect, like we do all the other disciplines which people value. And so I think starting a full research program and doing things like Ian's doing, where you actually start generating some data and some information, I think they may also start to raise its prestige.
Thank you. The back, right. Thank you.
Hello, my name is Didier Cornell from HEALS, Healthy Life Extension Organization, Healthy Life Extension Society. This panel is about revolutionizing care, and I think that the best way to revolutionize care for older people is to invest dramatically more for medical research against disease related to old age. And one of the very positive aspects of this medical research against this disease is that it is potentially useful for the most citizens of the world. each day 100,000 citizens, 100,000 people are dying from disease related to old age. So my question is to all the members of the panel, what are you doing to promote medical research against disease related to old age? And what do you think that the International Federation on Aging should do? Thank you.
Thank you for that question. And I'm going to exert my authority and I'm going to respond partly to that question. When you consider that 63% of the deaths globally are related to non-communicable diseases, clearly the emphasis, and we're not talking about older people or age, what we're talking about is lifestyles. In many cases, lifestyle diseases, where governments need to invest money in health prevention and health promotion, to cut the rates and risks of non-communicable diseases. But it's moving away from a disease focus to a health focus, one where people remain healthy and active, is actually the way forward if we consider that 63% of deaths worldwide are through NCDs. So I really do believe that it's a health prevention, health promotion model that government should be focusing on. But they're long-term strategies. Governments are empowered for short-term. 4 years is not long enough to see significant change in reinvesting money into different types of services where we're promoting healthier lifestyles. That's from my point of view, but that's where governments should be focusing a lot more effort. Panellists. Yes, Ian.
Thank you for that question. I was privileged to work in national government over a period of 8 years where the priority for research in diseases and their treatment and prevention shifted from a focus on heart disease and cancer to stroke and dementia. And that is a correct response of government to the changing threats to healthcare. And I also was in India at a celebration of 50 years of the All India Medical Institute. And the conference was held in the year where the health burden in India came from chronic diseases more than communicable diseases. For the first time, there had been that shift. And the institutions in India were thinking how to respond to that. And I have to say, this is the other side of the question regarding disease research versus other types of research, that by the time you're in your 70s or your 80s, you are likely to have several chronic diseases, and that while we need to invest in research to prevent and to treat, we also need to focus on their impact on people's capability for enjoying a good life that is meaningful to them. And I know from the work we're doing in India with the Easy Care project that we're getting a lot of government support to look at living a meaningful life in spite of having a number of chronic diseases. And I don't believe it's either or, but I think it has to be all of these things.
John, do you have a comment on this particular one?
Yeah. I think there is very exciting research to be done looking at the risk that age brings to all sorts of diseases. Why do we get, are we more likely to get these diseases as we grow old? And I think there's some very fundamental lab-type research that can start to fill the gaps in our knowledge. We've been encouraging, for example, a research program looking at immunosenescence across life. Immune function deteriorates. Why? If we do something in middle age to improve immune function, can it actually reverse the impact that can be associated with that and with what's also known as inflammaging? So I think there's a lot of fundamental basic research that can be done. That's number one. But number two, as Greg says, we already know that smoking kills people. We already know that poor diet kills people, lack of exercise. These are things which we can do today to get people to live longer and healthier, but we can't do them. In countries around the world, there is a lack of basic legislation preventing or discouraging smoking. And we can't create cities and environments which encourage physical activity and encourage and help older people to be able to get to the shop and buy healthy food. So there's also things which we do know, and what we need to do is figure out how to get people to do them. And then third, no matter how good a job we do at both of the above, there's still going to be a lot of people who end up requiring support and care in the last years of their life. And we need to figure out how to do that better too, because there's millions of people around the world who don't even receive basic support and care in their last days, and we need to change that. So I think we need to do all of the above. I think our role is to focus on the poorest and most vulnerable, and they're generally the people at the end of life who actually need some decent care, and we need to get some basic principles out there to see that it's delivered to them.
Thank you, John. And I know Graham has been involved with organisations in Western Australia dealing with issues around brain health. So those things certainly, and Alzheimer's disease. So certainly there is work going on, but I take your point that there needs to be much more work done. One more question, yes, please, and then we'll wrap up.
Thank you very much. My name's Rob Anderson. For the last 4 years, I've been the president of the European Association of Informal Carers Organisations. And over those years, we've seen a growing interest and attention at the policy level to the situation of family or informal caregivers. What I want to know is, how can we translate that growing awareness into action to really support family or informal carers? And one of the themes that came through the first two presentations, at least, was the need for systematic assessment on a continuing basis. And I think that needs to be done for family or informal caregivers. But what incentives can we give to whom to do that? Thank you.
Would anyone like to respond to that? Yes, John. Oh, Ian.
Well, I think we'll probably all respond to that. It's a great question, but it's also depressing that the question still has to be asked, because we haven't translated the knowledge about interventions to support informal caregivers into systematic action in many countries. I see that. If I took, and forgive me for this, if I take an easy care approach to the question, the easy care approach is to start with finding out when informal carers feel they need help and finding out what help they want. And we may be surprised, because it isn't always respite care. It's usually not bringing others in. It's sometimes the recognition, it's sometimes simple forms of support to enable people to continue caregiving. And one of the revolutions I think we still have to go through is to stop being apocalyptic about the burden of caregiving and realize that there are doable things where we can make a big difference.
Thank you, Ian, and thank you for the question. And I am going to close the session by asking you to join with me in thanking our speakers for this final session today. And finally, I would like to thank those of you who are left in the room today. I know it's late, it's been a long day, but it's certainly an enjoyable session and I'm glad you stayed. So just a reminder, 7 a.m. breakfast, room A, block A, followed by business leaders panel at 8 o'clock tomorrow morning. So thank you and good night.